Okay, good morning and welcome to the Oregon Cancer Foundation's third annual Topics in Breast Cancer Conference. My name is Amy Johnston and I'm the director of the Oregon Cancer Foundation, and it's my pleasure to welcome you here today. Before we get started, I'd like to take this opportunity to thank our event sponsors. They are Eisai, Genentech, Gilead, Seagen, and KMTR NBC 16. This conference would not be possible without their support, and we thank them for their belief in our mission and their participation here today. As I said, my name is Amy Johnston, and I'm joined here by Andrew King, who is our program coordinator at the foundation, and the two of us are your facilitators for today's webinar. All right, with no further ado, I'm going to introduce our first speakers for today. The first session is Genetic Testing Saves Lives, and our presenters for this session are Drs. Winnie Henderson and Dr. Christine Cole-Morgan.
All right, welcome everyone. We're two surgeons at Oregon Surgical Wellness, and we're very excited to bring you today some of our newfound knowledge on genetics. And truly this genetic testing for hereditary cancer syndrome truly saved lives. And at the end of the talk, you'll realize why this statement is true. We started this practice, we've been very, in surgical practice for a long time, but we started our practice, this one, Oregon Surgical Wellness, in 2021, incorporating a lot of the innovative and programmatic programs in surgical care. And one of the proudest accomplishment that we have is our breast cancer surgery program. And, having a surgery program naturally evolved into taking care of high-risk patients also in our community. As we get a lot of referrals for such, we encounter a lot of patients with genetic mutations, and we thought about our knowledge base in this area. And it turns out that a knowledge base I would say, not optimal. And so we actually made ourselves go back to school and get additional knowledge in genetic cancer risk assessment and management through the City of Hope program. This program was pretty intensive. And the program truly was designed after finding out, or as we observed, that surgeons' volume and experience appear to really matter with genetics, cancer risk, and counseling, and surgical decision regarding how we present the options to the patient are very all over the place, and it can result in care disparity if your surgeon's not knowledgeable about genetics. And this study in 2017 demonstrates this. Additionally, it turns out that in the country, in this 2017 study, 43% of the quote-unquote experienced surgeons offer breast conservation in patients with BRCA1 and 2 mutation. And this is definitely not the NCCN guidelines. These mutations are the major mutations that cause breast cancer. 25 to 50% of surgeons reported mismanaged of VUS. It's called variants of unknown significance. As people get genetic testing, they can get 3 results. They can get a positive results like BRCA or other genes, or they can get negative results. And the last one is VUS, which just means that patients have a mutation, but the mutations are not related to any disease or cancer right now, and we put that aside. The mission of genetic risk assessment and management is to prescribe high-risk screening, preventative care, and target treatment for those people, individuals who have inherited cancer risk. And there are guidelines and resources provided to clinicians, primary care, surgeons or any doctor who evaluate the patients, and recognize and refer the appropriate patients to providers who are certified in genetic cancer risk assessment services like ourselves. And we help manage these patients and the family with cancer predisposition with a lifetime plan moving forward. And these are the different hereditary syndrome. We are obviously a breast surgical oncology practice, but we actually test for all of these different kinds of genetic syndrome, as you will quickly realize that there are a lot of genes that are involved in cancer. And with so many choices, one would wonder, what to order, but with our knowledge base, we are able to help. And so last year and at the beginning of this year, we actually completed an intense course with City of Hope for genetic cancer risk assessment. We have been inducted into the clinical cancer genetics community of practice by City of Hope. I recently get certified by the National Consortium of Breast Center for cancer genetic risk assessment as well. So with this knowledge, we set out a genetic cancer risk assessment and management clinic. This is our brochures. We're going to go through this real quick, but one may be interested in asking a question, should you be tested? So usually patients who have a family member that had diagnosis of cancer less than age 50, has 3 or more people in the family with cancer, or have a member who have been diagnosed with or yourself or a family member been diagnosed with more than one cancer, and also somebody in your family has a gene mutation, as well as being Ashkenazi Jewish descent. And the process is that we get the referral for you, and then we will screen you using a virtual tool, and then bring you in for pre-test counseling, and then draw your blood. This will lead to the results, and we will get the results back 2, 3, 4 weeks after the blood draw. And if you test positive, we will bring you in again and have a counseling session about what the gene mutation means to you and your family. And then we will coordinate with your primary care doctor and refer you to other practices that will help you with a risk management plan for future intervention. And this, again, is just a brochure. So knowledge is power, right? And implication for your family, for genetic testing. After a gene mutation, everybody's worried in the family about, oh, does it affect me? And then some of the gene mutation actually have therapeutic implication. There's a new drug that comes out that is very, very effective in treating breast cancer in BRCA patients. So identifying those patients who are BRCA positive become very important. We can design preventative strategy, including surgery or medication. We'll give patients intensive monitoring. We believe that early cancer detection is really important, and provide patients with surveillance prevention. And this has been proven to increase survival for at-risk patients and decrease our community's cancer burden. And these are kind of the strategy, say this is an example of BRCA positive patients, all the things that we could do to help prevent cancer for them. Who should get tested? Again, just want to bring this home. Young patients with cancer, strong family history, rare tumors, therapeutic implication. The NCCN guidelines is what we go by. Currently, triple negative breast cancer, pancreatic cancer, and metastatic prostate cancer all qualify for genetic testing. And if one has multiple tumors or their family or themselves have syndrome, certain features, then they could qualify. And we, again, people who qualify by NCCN guideline. Now, a little bit about the genetic cancer discovery. It's only been truly about 30 years. Mary Claire Kane actually mapped the first cancer gene to chromosome 17 in 1990. And the discovery is actually in 1994 of BRCA. And we've come a long way. And as far as what we have done in science with the gene discovery and now leading to sequencing of the human genome. One may or may not know that Newsweek in 1993 had this, this is before the discovery of BRCA mutation, the hunt for the breast cancer gene. Joe Cunningham, 59 years old, had breast cancer. Her daughter, at the age of 29, had preventative mastectomy without knowing anything about her genetic makeup. And then the question is, Alessandra, who's 5 years old at that time, is now 34. And I am pretty sure that her family is now getting genetic testing. So we only in short of 30 years, we have come a long way in genetics testing and risk assessment. This is really interesting. This is actually the front cover of Science, which is one of the very respectable publications in scientific discovery. This is the front cover for BRCA gene mutation. This is published in 1994. The cover is actually a piece of art that was drawn by Hollis Segler, whose family actually suffered from breast cancer. And one of 9 women in the United States would get breast cancer. And she had a series of arts that convey the emotional impacts of the disease. And then, I can't remember what year is this. I think 2006. Is it 2006? My slide has the year all the way up top is covered. 2006, Angelina Jolie actually put genetic testing in the spotlight. As we all remember, everybody's concerned about getting bilateral prophylactic mastectomy. And then in 2014, this article that this Science magazine again have a 20-year review of what has been done after the cloning of BRCA1 mutation. And again, this cover is a painting by Hollis Segler. Unfortunately, she passed from breast cancer in 2001. And then now we are able to provide genetic cancer risk assessment and management at Oregon Surgical Wellness here in Lane County, allowing us to discover patients who are at risk so that we can lower our cancer burden in the community. Dr. Kohlmorgen is going to take over from this spot.
All right, this is your break. Shake it out. We're almost there. We're almost ready to land it. So hopefully from listening to Dr. Henderson, my partner, you're getting a sense that, again, this is a little bit of a tricky business. It's very detail oriented, and it definitely behooves all of us to start engaging in this knowledge a little bit. I think if you look at that history, this knowledge is taking off. We will go from being in the dark to being in the know. And as you all know, once you're in the know, then we have to decide, what do we do about that knowledge? And that can be sometimes scary. And one of the reasons why we're here is to help, peel back the layers and help people understand how to use this technology to actually bring peace, calm, and security to folks, not the opposite. I like this slide because it still shows in this light teal blue over there on breast cancer. Most breast cancer is not related to a family member that you know of, or even in the family. It's just what we call sporadic. Someone just developed it. They don't have a gene, and there's no known family member that has breast cancer. In the yellows, you can see that small little sliver in the 5% range. That's the actual sliver of all folks who have breast cancer that actually have a known genetic mutation. So it's a small subset, but when you're talking about many women who develop breast cancer in the country, if we can help the prodigy of those folks not develop cancer, that's a huge win for a lot of people. This slide sort of depicts, of that 5% slice, what are the genetic mutations that folks might have. And you can see that BRCA1 and BRCA2, the Angelina Jolie gene, is really the most prominent gene that portends to having a risk of breast cancer later on. And this is just another somewhat complicated slide, but really meant to depict sort of the myriad of different genes that predispose us to cancer and how they're all related. Some genes may predispose you to breast cancer, but also ovarian cancer and uterine cancer. Some genes have colon, pancreatic, melanoma, and breast, and so on and so on. And part of our job is to help you identify as a patient, if you happen to end up with a genetic mutation, what other cancers other than breast need to be screened for, and what types of things are actionable to reduce that risk. That's the point. Let's reduce the risk of cancer. As Dr. Henderson mentioned earlier, breast cancer genes are associated with a number of what we call hereditary cancer syndromes. You've got your BRCA, your PTEN, STK11, TP53, CDH1. These all are the locuses where these genetic mutations occur, and they're associated syndromes that some of you may have heard of in the past. Maybe these are all new types of syndromes that you've never heard of, but those are where things become associated, and these types of syndromes run in families. I'm not going to spend a lot of time on these very complicated slides, but what they're really meant to depict is that there are a number of genes that have high risks associated with them, and they're actually what we call actionable genes, where you could either take a medication or have a surgery to prevent or significantly lower your risk of cancer. And then there are a number of other genes that are more moderate risk genes that we want to screen you for, and make sure that you're knowledgeable that yes, while your risk is higher than the average population, it's not so high that you actually need to have your breasts removed or your ovaries removed, but there are things that we want to do to make sure you're screening for them. And again, these are complicated slides, but I think it's really meant to depict the fact that this is very detail-oriented work, and it needs to be done not cavalierly. This actually helps folks understand their genetic risk over time. So let's just look at that top graph in the middle, BRCA1. You can see as you go along, the bottom red line is the average population of risk to breast cancer. So at 65, you're creeping up to 85, you've got that sort of 10% or so risk that you're going to develop breast cancer, versus that blue line where you really pop up, and there's quite a bit of difference between the average population and you if you happen to carry that gene. It helps people understand that risk isn't tomorrow, it's a lifetime risk. And we use graphs like this to sort of work folks through their risk of cancer if they have a gene. You may have to help me figure out how to start this slide.
Yeah, so if people have a gene mutation, basically they will They will need sometimes surgical care, and let's see here.
We're gonna try to play this video for you.
I
that-
am not sure what happened to, oh, right
Oh, there
here,
you go.
sorry. If they have a genetic mutation, say BRCA1 or those high-risk genes, they may want to consider mastectomy. And we are a comprehensive breast surgical center that will be able to provide hidden scar surgery, which is basically not having a major scar with a prophylactic surgery. And this video will show you the experience of patients in that situation.
I feel relieved and lucky that I found out I had the mutation. I didn't want to go through what my mom and the rest of my family has gone through. My mom felt really bad that she gave me this mutation, but I told her that she saved my life, because if it wasn't for her having cancer, I would never even know.
The BRCA mutation is an inherited, what we call deleterious mutation that significantly increases a woman's risk of developing breast and ovarian cancers. When you have a BRCA patient who doesn't have breast cancer, her decision to have surgery is not urgent. It's an elective decision that, in my mind, it's like a life-saving operation.
If you don't ask, you'll never know. I found out everything that I could about cancer and surgeries and what I can and can't do. I could either chance it with an 88% chance of getting breast cancer, or I could just prevent it from happening and have a double mastectomy.
We took the concept of hidden scar to her, and she was very interested in it. What we're aiming for and what we achieved with Kimberly was to enable her to look at her body in her bathroom mirror and not be reminded every day that she had a bilateral mastectomy. She can look at herself and feel normal.
Being a woman and a single woman, it does matter. It matters with your confidence. It matters how you feel about yourself, how you present yourself. So I had no problem telling him, I want to look good. My mom's incision, you can't see it when you're looking at her, but if she does wear a bathing suit, you do see a little incision. In mine, you cannot see it all. I would actually have to lift up my chest for it to be visible. If you really don't want scars, or if you don't want people to know or anyone to see it, you need to figure out a way to do that. And if that's asking 100 questions to 15 doctors, that's what you have to do. Having the hidden scar procedure, I think, allowed me to make it more private. You don't have to be reminded every time you wear a bikini, and it gives you that option to tell people or to keep it to yourself. My results are amazing. My breasts look better now than they did prior to my surgery, and I like the way that I look. And now I don't have to worry about having cancer. It's not on my radar anymore. I can move on with my life and not think about that and not worry every single day about when it's going to happen or if it's going to happen. I can just move on with my life.
So, that's a pretty powerful story, I think, about, again, someone finding out that they have a genetic mutation and then having to go through the brave journey of figuring out what they're going to do about it. One of the things that was very important to Dr. Henderson and I was that we could actually offer a solution that was acceptable to our patients. And of course, the hidden scar technique, which both Dr. Henderson and I did extra training to become certified in, working alongside with our plastic surgeons here in town, was again something that we felt important that we needed to add to the community. Of course, not every patient is a candidate for a perfect hidden scar procedure. This particular patient, of course, was, but when and if it's available, we really wanted to make sure we could offer that. We're also certified in what some were called oncoplastic surgery, which is again the marrying of both the surgery for cancer and having an outcome that's cosmetically pleasing. They're not mutually exclusive events, and that marriage is something you need to work on to obtain excellent outcomes. Oopsies.
Yeah.
There we go. I wanted to run through, with a bit of time that we have left, some pretty interesting cases that we've come across along the way. well, we've embarked on this journey. The first one was a 42-year-old man. So this isn't just for women, obviously, who presented after undergoing mastectomy for gynecomastia. That's the excess breast tissue growth in a male. It was really done as a cosmetic procedure for him. And lo and behold, he was found to have something called atypical ductal hyperplasia. That's a precancerous tissue found in breast tissue. He was seen in our genetic cancer risk assessment clinic, and he agreed to be tested because this is an indication for testing based also on his extensive pedigree, which showed a fair amount of breast, ovarian, pancreatic, and one family member with pancreatic cancer. And lo and behold, incidentally, accidentally, he was found to have BRCA1. We developed a risk management plan for him, and of course, offered cascade testing to his immediate family members, which is done actually for, I don't want to say for free. The visits aren't for free, but the testing actually is offered for free for immediate family members who actually test for an actionable mutation. And 3 of his sisters were tested. So this is just an example of, paying attention ended up with an incidental potential life saved. The other story is also interesting and highlights why we all need to be paying very close attention to the results. This was a 43-year-old female. She appropriately tested as she was Ashkenazi Jewish and was found to have a genetic mutation called CHEK2. She went to visit with a surgeon who offered her a double mastectomy as a risk management plan. And fortunately, she wanted to have a second opinion about that. She came to Oregon Surgical Wellness, and we delved into the actual CHEK2 variant that she had, which was not the standard variant. It was actually a much less pathologic variant, meaning the risk for her to have breast cancer was, yes, indeed, higher than the average population, but certainly not high enough to have an actionable double mastectomy. We counseled her, and she ended up not having a double mastectomy and rather chose to move forward with a more intensive risk management plan, which included screening, physical exams with us. Not to get too much into the weeds, but the bottom line is we had access to presenting her to a multidisciplinary genetic cancer risk assessment nationwide conference at the City of Hope. And her case was presented there, and she got the collective knowledge of experts all across the country just by coming in to see us. So fortunately for her, she chose to have a second opinion. The next patient is a 60-year-old man who had metastatic prostate cancer, meaning his prostate cancer had spread beyond the prostate gland. That is an indication in and of itself to be tested. He was tested and found to have biallelic CHEK2 mutation. Biallelic means it actually came from both sides of the family. This prompted cascade testing in the family, and he has a lot of children with a lot of females in his family. And yes, indeed, there were some CHEK2 positive, as well as a BRIP1 mutation, which was found. And we were able to counsel his family members about what to do in terms of lowering their risk and or coming up with a risk management plan that was acceptable to them. So this doesn't just affect the N of one. This typically has a ripple effect in the family and can bring about significant change in a family's health. We typically will use some tools that we have access to that we learned about through our visit and education with the City of Hope. One of them that we use is Ask to Me. Ask to Me really drills down on your specific risk, not just, oh, I'm going to Google CHEK2 mutation and find out what the risks of CHEK2 are. But let's say I want to specifically set out about what my personalized risk is. And this actually allows us to do that. Again, here's what I spoke about earlier. This green line is the non-carrier or the average person, and the blue would be a carrier. And you can see the dramatic difference in someone's breast cancer risk when they have BRCA2. Again, a specific risk for a specific patient who would come in to see us.
And wanted to add is the age of testing. Also, if you were to have lived 60 years without breast cancer with the BRCA2 mutation, comparing to one who is 35 years of age coming in, then obviously you can see how much higher the lifetime risk for the 35-year-old. So when a lot of our patients come in their 70s and 80 with a BRCA mutation or other high-risk mutation, we actually don't recommend bilateral prophylactic mastectomy. We just recommend intense screening. So that's it's kind of help you figure out your age-specific risk and what to do moving forward.
And sometimes that's tricky to understand when you're just being thrown numbers at you.
Mhm.
You know, when you're a 60-year-old who hears they have BRCA versus a 35-year-old who hears they have BRCA, you think, oh my gosh, the same outcome is going to happen. But when you actually plot out risk per age, it wouldn't really make a lot of sense for a 60-year-old to have a double mastectomy. You can see their risk in their lifetime is only twice that of the average population versus fivefold in a younger
But if they
person.
choose to do so, it's okay, because after all, they do have a mutation, and occasionally women just want to have a peace of mind.
We also provide a lot of patient education materials and help curate different websites, different applications that folks can go to really help them understand their genetic mutation by gene type, by genetic syndrome, and by genetic mutation. FORCE is one of those. It's a wonderful site for someone who's discovered to have a genetic mutation. The Susan Komen site also has a plethora of knowledge available to the public, and we help our patients find different decision aids and tools for themselves to make sure that they're as educated as possible before they make a major decision. There's also genetic counseling for people who do not have breast cancer to learn about this. And in summary, you know, we just really want to hammer home that the proper interpretation of genetic results is essential to having the correct personalized care. Every patient is a bit different, and every outcome is a bit different, and every patient's desires are a bit different. And we try to correlate all of those before someone makes any major decision, particularly about surgery. So at Oregon Surgical Wellness, you know, breast cancer, our high risk breast and genetic cancer risk assessment and management clinics really are focused on providing that for our community. And bottom line is hereditary cancer syndromes are out there. Screening is going to save lives. And it's a simple recipe of testing, counseling, and managing and referring. So thank you so much for listening to our talk. It's a topic obviously passionate to us.
And we, if you feel like we kind of rushed this, you know, there's a lot of information. We just want to get everything out and be able to, you know, spread the words about, you know, the availability of genetic testing in our community. And this is a relatively new testing service actually in our community, because most of the patients used to have to go to Portland or elsewhere to do all of this, but now we have this available. So I'm going to stop sharing a screen. You have to bear with me, our mouse sometimes goes to sleep. And I see that there are some questions.
Thank you so much, Dr. Henderson and Cole Morgan. One of the things that we're always amazed by here in our community is just the range of expertise and knowledge that cancer patients in our community have access to. I think it's really incredible. We did have a couple questions come in. The first one was from a participant that says, as a BRCA2 breast cancer survivor, I have a brother who may be at risk with a more than 50% chance. Do you see men for genetic testing in your clinic?
Absolutely, we see men. This is not a male or female issue. It's a people issue. So we'll see everyone. And it's very important to have family members be counseled. And we're always happy to see a family member of someone who has a known genetic mutation.
Let me add that, we have discovered a lot of patients in our community who actually have been tested, but they may not have had the proper counseling. What I mean by that is that a lot of providers actually order the tests and then they give the results to the patient, and they depend on the genetic counselor to give do the counseling. And from our patients, from what we have been, our experience is that the genetic counselor is able to tell you what the genetic mutation means, but they are not, usually the line in the report will say, refer to your provider for management. So this is the part that is truly missing in a lot of the counseling. So when we actually talk to patients who have a genetic mutation that we didn't test, we actually offer a counseling session regarding these different genetic mutations and the implication of the gene mutation to their family. We give them lots of information, handouts about their gene, their risk, what to do, what kind of cancer they are at risk for, and also management, who you should see, say if somebody come in with a breast cancer, or they were thinking family history of breast cancer, and then they tested for positive for another gene, say for gastrointestinal cancer, we actually can initiate the referral from our office for them to see a gastroenterologist to increase colonoscopy, endoscopy, ERCP, MRCP, all of these, because we're doctors and we're able to place orders, unlike the genetic counselor. So I think that genetic testing is being done, it's always been done. Genetic counselor has advised the patient. What the part that is missing in our community so far is management. And we, because of our knowledge from our intense course of City of Hope, we are able to give patients a plan so that they can walk out of here feeling more comfortable about what to do with this information.
Yeah, the other thing too is that it's an evolving science. So a lot of folks may have been tested 10 years ago, and what we do now versus what we did then is different. And so it's nice to be able to plug into a continuous, up-to-date entity for treatment and management.
I think we still have a few more questions. We only have about 5 minutes left, so I want to get to these real quick. And then I think what we're learning here is that maybe we need to do a follow-up session with the two of you, because this is a wonderful topic to cover, and I think we could do it in a lot more depth. But the first question was just NF1 gene risks, question marks.
Yeah, so I have an NF1 gene mutation patients. There is basically a risk for breast cancer, but truly it's depending on multiple different factors. For these type of rare genes that is not the high risk, a patient really benefit from coming in, having a discussion, and in situation that is confusing, we can present their case to the City of Hope conference to decipher, get some recommendation about what to do with a gene mutation. So
we have another question. I'm going to combine these two together. So two-part question. It says, are there known reasons why some people with BRCA 1 and 2 do not get cancer? And are BRCA testing by 23andMe adequate for test results?
Ooh, that's a long answer. And which we won't have time to answer fully, but again, these are risks for developing cancer. So, that's not all, none of them are guarantees. And that would delve into why folks actually get cancer with BRCA to begin with, which we could talk about, and it's very interesting. The second part of that question is commercially available genetic testing kits are, they're a good start. However, they are going to miss up to 15% of the nuances of some of these mutations. So we recommend that if folks are truly interested, they should have a 29 gene panel, which is one of our standard panels, but it's a blood test preferably, and it's going to be the most accurate test that is available at the moment for patient use. So
Okay.
yes,
23andMe test very superficially, and maybe just to add that not every gene mutation creates a dysfunctional protein. Okay, so a protein is required for certain function in your body. So basically, you just need to, know which, what your gene means really, because it can be many different one that affects the one gene, different mutations affecting one gene.
So thank you. The last two questions we're going to try and get to in the last 2 minutes here. The first one is, if an individual has breast cancer and their mother did priorly, would it be recommended to send the daughters to be genetic tested?
Yeah, I think
For
it's
sure.
very, for sure,
Yeah.
because now we have 2-3 generations of patients with cancer. We actually see these patients all the time at our high-risk breast clinic. So we are able to provide guidance to what to do with the empirical risks, which is based on family history.
Okay. The last question I think we're going to have time for is similar in nature, but it says three of my first cousins have experienced cancer: ovarian, uterine, colon, lung. I have no siblings. Mother had melanoma. Great grandmother had colon cancer. Should I be tested?
Yes, definitely.
Okay.
And we have to screen her. We just need a referral from, depending on your insurance, referral, not referral, and we can get screening done and counsel you.
So I said that was going to be the last question, but there was a comment here put in the chat that says, has medical insurance caught up with genetic research, or is this financial expense transferred to the patient? I understand that the doctors may not know the answer to this, but perhaps they can bring attention to how important it is.
But we do know.
we do know the answer to that. The nice way that our program works is insurance basically goes by what's called NCCN guidelines. And so the bottom line is the average out-of-pocket expense for patients who do meet criteria to test is about $150. So yes, thankfully, the answer to that question is yes.
And because we screen by NCCN guidelines, if you don't qualify by NCCN
You don't get a
guidelines,
test.
then
need
you
a test.
probably don't need a test, because you could be, your risk is actually fairly low.
Okay. All right. And let's see. There was one person who asked if we could answer their question, but I do not see it. Oh, I see it. I do see the question. This person says, my niece and nephew may be BRCA positive. When it is overwhelming and scary, what might be a good site to refer them to initially read about it, where it wouldn't be so overwhelming, but would give them basics? They're in their 20s, and my mom died of breast cancer in her 30s.
So we don't know if those family members truly have the genetic mutation. So it is up to them to decide whether they want to be tested. So sometimes the knowledge of knowing, it's actually settled the nerves. But if they want to, I would highly recommend, if they are that concern, they should be tested because we can, they can take it from there. Because if you truly don't have that mutation and your family has it, you're lucky because you only got the good gene, right? So testing is actually vitally important. But if they want to know about, what the genetic mutation mean online, we presented at the end of our slide. Force is a patient-facing site that allow them to click on the gene and have a description about, what the gene means, so forth. But remember, individualized risk is also important. And truly, people in their 20s, if they have the BRCA mutation, they start screening their breast. We start screening their breast at the age of 25. So if they are younger than 25, I don't really think that they need to
Worry about it
right now. Yeah.
Okay. All right. Thank you both so much. This has been really, really informative. I wish we had more time with you, but we're going to need to jump off so that we can start the next session on time. Again, thank you, Dr. Henderson and Cole Morgan. You guys are awesome. Thank you so much for your time and sharing your expertise this morning.
Thanks, Amy.
We'll always love to spread the words of our knowledge. Thank you so much.
All right. We'll see everybody in the next session in just a moment.